So thank you very much to Talk Lipoedema for asking us to come along and speak today. So we're here as two representatives of the Scottish Lymphoedema Practitioners Network, which is a group of lymphoedema specialists. There's a representation from each health board in Scotland, and we meet at least 3 times a year but communicate with each other all throughout the year with any problems. We work as a network to help each other, and our role is there to try and provide better services for patients living in Scotland. So we're going to do a bit of a double act. So I'm going to do some of the slides and then Connie's going to take over. Just as a starting point, we tried to provide some sort of information on the number of patients that we're seeing in our caseloads. When you look at the slides, you'll see that across the bottom there's figures from Tayside, Highland, Forth Valley, Ayrshire and Arran and Greater Glasgow and Clyde. The blue ones were figures of the number of people in our, it's represented as a percentage to try and make it even, of our caseload in 2019-20. And the sort of orangey colour is in 2022. So you can see how our lipedema referrals as part of our caseload have gone up in that time. So the referrals usually by the GP, but it's often prompted by self-diagnosis now, that we find a lot of people come to our clinics, they've gone to the GP to say, I think I've got this condition, and that's how they've got the referral in. Sometimes it's a misdiagnosis of lipedema has been given, but also it's missed as quite often it's been missed as a diagnosis from the referrer. So quite often we'll get a referral into the lymphoedema service saying the person has lymphoedema in their legs. When they come and see us, it's actually lipedema. So they've come down a sort of unusual path to get to us. When we looked at the sort of more national figures, so the National Lymphoedema Partnership works across England, Wales, Ireland and Erie and Scotland. And part of our big problem is that we don't have data, we don't have a good way of collecting the figures. So when we try and tell people how many people are living with lipedema, it's very hard because we just don't have a good way of collecting it. We have no coding that we can use, so most conditions in the health service have a definite code so that when you go onto the statistics, you can ask them to pull the figures for people living with a certain condition. We can't do that for lipedema at the moment. But when we looked across our sort of colleagues across Erie, Northern Ireland, Scotland and Wales, these were the percentages again of their caseload, and you can see about between 8 and 14%. Scotland seems to have a higher rate, maybe that's because of the work Talk Lipoedema doing, that are actually coming through their clinics. But at least 10% of our caseload as lymphoedema specialists is lipedema. So we were asked to sort of talk about what we would do if you come to a clinic, or what's a patient-centred clinical appointment assessment, what are we doing with you? So we thought, what are the expectations? So what's the person attending with lymphedema expecting from the assessment? And I think this next question is actually probably one of the key ones. What's important to that person? What's important to them? But also, what does the clinician want to find out? And what does the clinician expect? All these long-term conditions are a partnership. We need to work together. So what are we expecting from yourselves? And at this point, I'm going to pass over the clicker.
Well, I was thinking, keep
do you
it
want
because,
me to click it?
well, because then I can say next slide, and it reminds me of kind of COVID times. So if we think about what's happened before your patient actually presents itself in the clinic, and that has changed enormously over the last kind of 15, 20 years. So 10 years ago, if a patient would come to my clinic, I wouldn't have lipedema on the referral. The patient probably would have had no clue about lipedema, never heard of it. So it was something that wasn't really that well known. Whereas now, because of the media, there's been documentaries on the telly, it's been in newspapers, there's Facebook groups, a lot of patients already come with an inkling that they think, oh, I think I might have lipedema. Sometimes even GPs will have actually diagnosed and said, I think this patient's got lipedema. So that has kind of changed. It still means that some of our patients have had a very long road and many years of going backwards and forwards to the doctor, often stop mentioning it at a point because they think, well, it's pointless. They never really look at my legs, or they just want to give me water tablets. And sometimes this could be something like either a new GP who kind of says, oh, can have a look at your legs, or the patient have seen something in the media and they think, I think I might have this condition, and decided to do something about it. So some patients might have seen loads of different people before they actually come to us, and as a last resort, they seem to end up in a lymphedema clinic. Sometimes there's a familiar relationship, so sometimes say, I think my mum's got it, or we've got patients who are very concerned about their teenage daughters, and even before you know, they even have lipedema, they might never get a lipedema, but it can be a real worry if they have young daughters. So some will come with a diagnosis, some will then have been either seen by their GP. There might be other healthcare professionals who know a bit about lipedema, and it could just be because they have a very good lymphedema clinic locally who's done a lot about raising awareness, who might have given a wee chat to the community nurses or to a group of physios. But a lot of people will kind of self-diagnose nowadays as well. Next slide, please. So when they actually come to the clinic, we are kind of looking at the symptoms, because there isn't kind of a definite test or diagnostic tool that will tell us, okay, you've got lipedema. So it tends to be a collection of symptoms that we would be looking for and kind of look at. So the physical symptoms is often, we would obviously look at the legs, but the whole body, their shape, what kind of texture their skin has, if they've got any bruising, do they report that they've got a lot of bruising, any hypermobility, because there's been kind of some discussions about kind of links with other conditions like Ehlers-Danlos syndrome. Then pain, which is kind of a big thing for patients. So we would ask about their pain, kind of what kind of pain, because if somebody just says they've got a really sore knee, just the one knee, that might be they have other problems, because having lipedema doesn't mean you can't have other health problems that could cause you pain. The psychological, emotional aspect of it, so there's often a discussion about how they feel about themselves. Has it an impact on their confidence? Do they suffer with anxiety and depression? All those factors will have an impact on their social and their financial life. So some people might become very socially isolated. Financial, so have they had to take time off work, had to stop work, or had to look for different kind of work. Issues with clothing, footwear, things like that. And then you really want to know, well, actually, how is your condition stopping you the life that you want to live? And so that you really look at the whole spectrum of their symptoms. So it's not just a physical aspect of it, and not saying, oh, you've got swollen legs and here's a pair of stockings and that will do kind of thing. You need to really look at the person, what matters to them, what is important for them. So what have they lost and would they like to regain, and how can we, you know, try and achieve that? Thank you. So in a physical assessment, we will look at kind of at the shape and the distribution of fat, because that's kind of one of the classic signs of lipedema. And so we look if that's present or not. But have a more detailed look at the skin, so we actually feel and touch the skin to see is there bruising, is there what's the texture like. We will test for things like pitting, which is if you press on the skin for a wee bit, quite firm, it will leave a dimple. So that would be a sign that there is actually a watery component to it. So that will help it maybe a differential diagnosis to actually come to the conclusion, well, I don't think you've got lipedema, I think actually you've got something else. We will take measurements of people's limbs, so most often the legs. So there's two reasons why you would want to do that. So you could just take measurements because you want to supply somebody with stockings, and then there's often a form and you just follow that and you take a couple of measurements. You can also do what we would call a volume measurement. So you actually measure every 4 centimeters up the leg and you measure the circumference. And with lipedema, both legs are affected. So it's not that you can compare one leg with the other. With some of our other patients, you can. You would have a normal leg and you have the swollen leg. So you can actually see how much bigger it is. But what it does do, if you take the measurements, it gives you a starting point, and you kind of always know when you look back what the legs were like, because although we know the fatty component of lipedema is not something that's going to disappear with compression stockings or whatsoever, but people's shape and size will change. So even with a lipedema patient, because their weight might change, that at least we know kind of what the legs were like at that given point. So that's important to do. Then we'll look at their mobility. So you can look at individual joints. Can they move their hips fully? Can they move their knees fully, etc. But also then kind of how they walk, because often the walking can be affected by it. If they've got any hypermobility, so that's kind of more mobility than you should have in your joints. And we will also look at kind of the body weight or hip-waist ratio and BMI. There's obviously discussions about how useful these things are, but I think if you take those measurements objectively and you don't really put any onus on it, then that is fine. Then you've still got data which might be useful in the long run when you're following a patient through their journey with lipedema. Thing as you know.
Was it? So we tend to say the diagnosis of lipedema is not as straightforward as we've heard. There are a few people that you think this is very clear cut, but it doesn't exist on its own. So often we're trying to work out what that group of symptoms coming together will lead us to the diagnosis. We want to make sure that we've ruled out other conditions like lymphedema that might coexist, obesity might coexist, but where are we at? So it's putting all those pieces together of your jigsaw to form a picture. And then, as the GPs just actually said, it's quite often quite a difficult conversation to have. We want to confirm the diagnosis of lipedema. Often that's not unexpected, but it can still be an emotional shock when you're telling someone that they've got a long-term condition, that we also have limited understanding of what the best way to manage it is. But also we quite often find in clinic it's actually quite a relief that people have lived with this condition for so many years. They've had this feeling, or they've been told so many times, it's because you're not losing weight. How about exercising more? Have you tried this? Have you tried that? And that feeling that it's something that they've done. So quite often just having almost that understanding and hopefully being able to share that information that actually it's a definite condition rather than something that of a lifestyle choice that they could have changed. We can confirm it's a chronic condition, but there are things that a person can do to be able to help to live well, and that's what our aim is. And we want to try and stop worsening of symptoms by trying to avoid any of the coexisting problems that we could get. Discussing management options. So what's realistic to expect and what support can be given? Now, let's say we're NHS based, so we have to be evidence driven. There's not a huge amount of evidence to support what we can do with lipedema, so it depends on what resources are available. But we try and tailor it to the individual and what is important to them. As Connie was saying, what is it that we can help you get back to? What would help you feel that you're living your life more fully and normally as possible? And the aim is always to give skills to self-manage, but with the healthcare professional there to support as is needed. So hopefully people can dip in and out of that service as often as they want to, but they have the skills to get on with their lives, that they're not relying on us. Challenges, there are many. This is just from our side of things. There's so much lack of information about so much of the pathophysiology. So much of it we're still working in the dark. We're not quite understanding why it happens, so that's quite difficult. We like to give information to people, and when we don't really fully understand it, that's quite an awkward position to be in. But I think things are changing, things are improving, and over the time that we've been working in lymphedema, with lipedema on the side with that, we are getting more knowledgeable, there is more coming out. One of the other big challenges is the lack of recognition in some areas of healthcare. So we're still having people waiting far, far too long for a diagnosis, going through too long a journey before they actually get some help, which is not comfortable at all. The recognition that lymphedema can exist with other conditions but may need separate management. Again, I don't know if this is something that's come across, but we tend to find in clinics that as soon as someone has a diagnosis of lipedema or lymphedema, everything in the world, every symptom they have, they get told, that was because of your lipedema, or that's because of your lymphedema. And actually, just because you have one of these long-term conditions, you can have other things going on as well, and they could be maybe treated well. So it's trying to pick out what's happening with that individual. There's conflicting thoughts on best management, and at the moment you could look at it either way as a challenge or an exciting time for lipedema, because there's lots of discussion. What actually should we be doing? What is the best management? Is compression the thing or not? There's lots of talk going on at the moment. We do need data. We need to be able to code this condition so that we can collect data effectively, and without data, then it's very difficult to put across that there's a problem. When we go to management, when we go to anyone who funds a service, if you've no data, then there's no problem there as far as they're concerned. So we need to find ways of collecting that. We know there's a very big variation of access and resources across Scotland. There is nationally, but across Scotland particularly. And from where to say, our official titles are lymphoedema specialists. Are lymphoedema clinics the best place for management of lipedema? Again, there's lots of discussion around that. We were talking earlier, and at the moment we feel yes, until there's somewhere else for people with lipedema to go. But whether in the long term that's the best place, I'm not sure. But there's also lots to be excited about. Here in Scotland, we've got Scottish Government funding. That's incredibly exciting. And for the last 2 years, there's been so much done. And the projects that Talk Lipedema are taking forward, like the peer support group, the education in schools, are just fantastic and so exciting to be part of. So it's something that we're definitely looking forward to and seeing what happens. And I think Scotland are definitely leading the way in a lot of these things. But people are talking about lymphedema nationally and internationally. Again, Connie and I have been around lymphedema quite a long, scary time now. And before, lipedema was hardly talked about. There wasn't much awareness. You never really heard it mentioned. And now people are talking. We're maybe still frustrated. And that's from a healthcare professional side, so I can only imagine from the people who are actually living with the condition. But at least there is now talk happening and projects getting funded. So that's where we are, I think. And I think that is us. Thank you very much.
Thank you.